Good morning, everybody. Welcome to Grand Rounds for Wednesday, January 15th, 2025, in case you were confused about what day it is. I'm going to start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. So today we have Dr. Danielle Bourque, who is a metabolic physician in the Division of Metabolics and Newborn Screening and an assistant professor of pediatrics at the University of Ottawa. Dr. Bourque obtained a BSc in biology from Dalhousie University and an MSc in medical genetics at the University of British Columbia prior to completing medical school at the University of Toronto in 2014. Following a 5-year residency in medical genetics here with us at the University of Ottawa, Dr. Bourque completed a fellowship in clinical biochemical genetics at the Hospital for Sick Children in Toronto in 2020. And she also, because she clearly is addicted to the need to learn, completed a second fellowship in rare disease therapeutics with Dr. Anil Khan at the Magic Clinic in Calgary. Dr. Bourque's research interests include natural history studies of rare conditions and novel therapeutics for inherited metabolic diseases. She is an active teacher with postgraduate medical education and is involved with provincial and national organizations advocating for care of patients with rare diseases. And the title of her presentation, as you can see, is Advances in Inherited Metabolic Diseases. Over to
you. So thank you guys for having me speak today. Before I start, okay, I just wanted to go through disclosures. I am not getting any payments at the moment from any pharma companies, but I am involved with the Ontario Health Expert Group for Inherited Metabolic Diseases, where we are advocating for better care for our patients. And I have received some research funding from some pharmaceutical companies. So what I wanted to do today is introduce what inherited metabolic diseases are. I know we don't talk about them too much, but I will tell you guys all about them. And then what I wanted to do was describe the current state of IMD care in Ontario, how patients access care, what care we can offer, where we can improve, and then maybe outline kind of the future landscape of IMD care in Ontario. So what are inherited metabolic disorders? So if you guys come up to the 3rd floor of Max Keeping Wing, we still do, I think, actually have one of those big printouts from Roche, but all the metabolic pathways. Metabolism is how our body uses the fats, the proteins, and the carbohydrates and the minerals in our food to make energy. That's what we explain to families. IMDs are genetic disorders that result from the dysfunction of one of these metabolic pathways. They are often related to a pathogenic variant in a gene that codes for an enzyme. This is the most basic version of metabolics. It's a genetic disorder that causes an enzyme to work improperly. And in Ontario, patients who have IMDs are looked after by doctors who have done specialty training in the management of metabolic diseases. Typically, traditionally, this has been people who've either done pediatrics and then focused in metabolics, or more recently, people who've done training in medical genetics and then an additional fellowship in metabolic medicine afterward. And we're kind of a newer specialty in the grand scheme of things. So starting in 1900, Archibald Garrett is like the grandfather of metabolics. He discovered alkaptonuria, which is a metabolic disease, and described a lot of different metabolic diseases after that. Then not a lot happened. And then in the 50s, we came to realize that a protein-restricted diet can help reduce some of the signs and symptoms associated with PKU, phenylketonuria. So we're working on a 75-year time frame at this point in time. Once those benefits of the protein-restricted diet were recognized, the ability to test people for PKU before they developed those signs and symptoms was developed in the 60s. And this is the advent of newborn screening. Over the next 30 years, some medical treatments became available, but really not until the 1990s did anyone invent an enzyme replacement therapy to give somebody that enzyme that's deficient. So now we're on a 35-year time frame from right now. And you can see here I have some other highlights of human biology. In 2003, the Human Genome Project was completed. And I use that in quotations because in 2025, it remains entirely incomplete. In 2006, Michael Garrity and Pranish Chakraborty started expanded newborn screening in Ontario. So we were no longer only screening for PKU and congenital hypothyroidism, but we added MCAD. And then further down the road, we added another 30 metabolic conditions since then. The first talk of gene therapy or first trials of gene therapy became available in 2010. This is the year I started medical school. So, now we're on a 15-year time scale. And in 2017, the first commercially available gene therapy, Luxturna, to treat retinitis pigmentosa became available. It's literally 8 years ago. Like, we're in this very, very short time frame now. In 2019, Zolgensma became available. And I think we started treating patients with it in 2020 or 2021 in Ontario. This is the gene therapy for spinal muscular atrophy, the most expensive drug on the market at just about $3 million for a one-time infusion for it. And we still are in this era now where we're learning how to use mRNA, we're learning how to use gene editing, we're learning how to use siRNAs to modify conditions, but we are very much in the infancy of these therapies. And so our entire field is 125 years old. So coming back to the basics, this is a biochemical reaction. This is grade 11 biology. You have a substrate, an enzyme works on that substrate, and it makes a product. Doesn't get much more easy than that. In a metabolic condition, the enzyme is usually what the problem is, and it's not working. This can result in the substrate building up and the product being deficient. Now, there's a whole bunch of different ways that this can cause a problem. The most obvious being we have too much substrate, and this is what happens in PKU. There's too much phenylalanine, it doesn't get broken down to tyrosine, and that huge amount of phenylalanine is causing PKU, it's causing brain damage, causing all. In theory, that substrate might be worked on by a different enzyme, and now that excess substrate is being converted to something else, and maybe that other compound is toxic. So this is succinylacetone and tyrosinemia. Too much tyrosine, we don't have the right enzyme to break it down, so we send it off to something else, and this is building up. This is causing liver disease, it's causing kidney failure, it's causing all the problems we see typically in tyrosinemia type. Now, if we have too much substrate, maybe it's inhibiting a second reaction because the second reaction is dependent on something different. So now we have an enzyme that's not working in a different part of the pathway. So this is something else is building up. So in organic acidemia called propionic aciduria, we have too much propionic acid, and that ends up inhibiting part of the urea cycle. So these patients get a secondary hyperammonemia because their propionic acid is blocking part of the urea cycle. So then we have a hyperammonemic crisis. Sometimes the problem is related to not having enough of whatever the product is. So for instance, if somebody has a glycogen storage disease, they're not able to either go through glycolysis or gluconeogenesis, and there's too much, not enough glucose. As it stands right now, we have about 1,500 different known IMDs, inherited metabolic diseases. This wheel was taken from a paper from 2021. Try your best to categorize every IMD based on its pathogenesis. And you can see here, it's not perfect because the spokes are kind of sticking out at all angles. So Carlos Ferreira, who is a metabolic physician in the United States, made this beautiful nosology of metabolic diseases, but even he couldn't get it to fit perfectly. Most of them are related to enzyme problems. Some of them are related to transporter defects. Some of them may be related to the respiratory chain. Some may be related to fat metabolism. Basically, any part of your metabolism can be affected by an IMD. Now, if we were to take our different conditions, all of them are rare. But if you were to look kind of taking them as a whole, are actually not uncommon. About 1 in 2,000 people in Canada, based on one of our studies, has an inherited metabolic disease. Some are more common than others. So PKU being a very common metabolic disease. MCAD deficiency, a fatty acid oxidation defect, is very common. And then there's things that are much, much more rare. And we had to kind of go through our clinic load a few months ago as a part of this. And I think we have about 500, give or take. This is pediatric and adults. About 40% of our patients that we care for in our clinic are actually adults. So we are one of the few programs at CHEO providing care throughout the life. My oldest patient is 82, and I have babies I get from the newborn screening program every so often. And my colleague, Andrea Yu, she's not here, is, I hope she's listening from her office. She has a very similar practice profile to me. And when we think of metabolic diseases, we tend to break them down into two small categories. So small molecules and organelles. So the small molecule disorders are the ones that stem from poor breakdown of the food that we eat. So these are your amino acidopathies, your organic acidurias, your fatty acid oxidation defects. Some of these come with a metabolic crisis or a hyperammonemia or a lactic acidosis type thing. And typically when we're treating these type of patients, we're modifying their diet. So we may say, you know, this patient needs a low protein diet. This patient needs a low long chain fat diet. We prescribe all sorts of vitamins and all sorts of minerals to treat patients, even though it looks kind of crazy. But, you know, I think one of the things I prescribe most common is actually vitamin B12. And then medications to help manage the condition as well. And so I do actually have to thank Andrea for this because she made this slide. So if we take the food that we eat, it's broken down into a few different macronutrients, so protein, carbs, and fat, as well as the micronutrients. So if you remember back to high school biology, you may remember that amino acids are the building blocks of protein. Typically, we think there's about 20 of them that we use. And an amino acid is obviously an acid group, but it also has ammonia on it. So when we break down an amino acid, we release ammonia. The ammonia goes into the urea cycle where it's detoxified and excreted primarily through the urine. The other part of an amino acid, so we have ammonia attached to an organic acid, that's an amino acid. The organic acids themselves get broken down to release energy. And organic acids, when they're broken down, they release acetyl-CoA, which feeds into the TCA cycle or Krebs cycle or whatever you want to call it. But these are disorders of protein. Disorders of carbohydrates can affect the three main types of carbohydrates we take in our diet, which are fructose, glucose, and galactose. They feed into the glycolytic pathway at different points. There are disorders related to all of them, but the main goal of the glycolytic pathway is to produce acetyl-CoA to run the TCA cycle. Acetyl-CoA is kind of like the common end of all of these different pathways. Our fats are broken down into individual fatty acids through beta oxidation, releasing acetyl-CoA, but fatty acid oxidation also shuttles its electrons directly to the electron transport. So fats are a very high energy food or macronutrient. They actually provide the most calories for each individual gram of fat, compared to protein or carbohydrates. Once you get to the electron transport chain, you move your electrons through it, and eventually you make ATP at the very end, which is the energy source for our bodies. There are also disorders affecting micronutrient metabolism, particularly vitamins, and vitamins are cofactors for a whole variety of different enzymatic reactions in our body. So when we are prescribing vitamin B6 or vitamin B12, it's to help optimize a reaction where that vitamin's the cofactor. We're not just like waving our hands, like we do have some evidence to back it up. And then the other micronutrients would be minerals. And so Andrea so thoughtfully put together where all of our different disorders fall into metabolism. So disorders affecting amino acids include PKU, MSUD, homocystinuria. You know, a disorder affecting galactose is galactosemia. Anyway, tons of different disorders. Beautiful high overview of them. Did you get your photo? Okay. The other type of disorders that we follow are what we call the organellar diseases. So these are less affecting those kind of food metabolism pathways. And these are problems with the cell organelles themselves. So the Golgi body, the endoplasmic reticulum, the lysosome. These tend not to have the same kind of metabolic crisis come up. These tend to be more chronic conditions where over time the condition does progress, but there's no like acute problem. And unlike the other ones where we change the diet, this time we'll give the enzyme that's missing. We may try and give a medication to reduce the substrate that's built up. Common ones that we see here would include Pompe disease, some of the MPSs. For those of you on the wards right now, I believe there's an MPS 3 patient admitted. There's a patient with MPS 6 somewhere, and I think a peroxisomal patient. I don't know everyone who's admitted right now, but I just kind of scanned the list. So right now, there's 3 patients with organellar diseases admitted to the CHEO ward. And how are we diagnosing patients? You know, quite often by newborn screening. At this point in time, and this changes kind of on a yearly basis, we're screening for just over 30 conditions. And all of these conditions are treatable, and they are most treatable before the onset of symptoms occur. The majority of them are still metabolic disorders, but we have expanded in recent years to include more genetic disorders. So spinal muscular atrophy, for instance, been screened in Ontario for about 5 years now. The structural organ ones include congenital cyanotic heart disease. We've also recently started screening for biliary atresia based on diaper samples. So this is kind of expanding all pretty frequently, at least a couple conditions a year. So 1965 is the magic year for newborn screening in Ontario. It was actually run from Public Health Ontario, and Pranish and Michael can correct me if I'm wrong. I believe it was actually run by dentists, not physicians at this hospital. I guess CHEO wasn't here in 1965. It was not run by physicians. It was actually run by, and for many years, it was really just PKU. Michael Garrity and Pranish Chakraborty did a lot of work in the early 2000s and brought the newborn screening program to CHEO. Which has actually had to be a big win for this hospital because obviously everyone assumed it would automatically go to 6 years, but that was not the case. So in 2006, they launched Newborn Screening Ontario here at CHEO, and it still is here at CHEO. You can go over to RI1. I can never tell it apart, and you can actually see the lab. Everyone who works in the lab and the counselors who were doing newborn screening rituals are all over in RI1. And so they added the first new disease of MCAD, which is a fatty acid. And over the next 2 years, they expanded dramatically. And as of last year, this is the list of metabolic conditions that are currently on the newborn screen. Most recently being added were Hurler disease and GAMP deficiency. And we've gotten referrals from the program for all of them. So now I know there's people from NSO here, but so basically after 24 hours of life, all babies are offered, and this is considered standard of care, a heel prick test where their blood is blotted onto one of those little cards. And this is at every hospital, every birthing center, even at home, midwives will offer this. Babies have their heel prick test. It's all sent here to the lab at CHEO, and they are analyzed for a variety of different conditions. So you can see here, the submitters are the hospitals, the midwives, whoever. They're all sent here. The NSO lab is open the vast majority of the year. So there is reporting all days of the week. There's a couple of holidays where they're not open. But other than that, we do get referrals, on New Year's Eve or what have you. And so the samples get sent here, they get analyzed, and then we get a call from NSO directly. We have a nurse who runs our newborn screening program. So she's contacted every day by the newborn screening lab to say, we have X, Y, and Z referrals for you. And then it is on our team and that nurse to make sure those babies are located in the community or the hospital if they're still admitted, and bring them in for medical. And as the regional treatment center for this part of Ontario, we provide then lifelong care for those patients if needed. So it's actually quite a complex but beautiful. So an example of one of the conditions from newborn screening is homocystinuria. This, as you may have remembered from a previous slide, is a problem with the amino acids. So when we eat, we take in amino acids, one of which is methionine. Methionine is acted on by a few enzymes to make homocysteine. And then homocysteine can actually be reconverted to methionine by methionine synthase, or it can be excreted through a pathway leading to cystathionine. The methionine synthase has folic acid and B12 as cofactors, and CBS, the enzyme for homocysteine to cystathionine, is got a cofactor B6. And these are going to become important in a few minutes. So when we're screening for homocystinuria, we're looking for classic homocystinuria, which is a deficiency of CBS. So while you can do the top part of the pathway, methionine, homocysteine, and back, you can't actually do the excretion part of it. So homocysteine builds up. And this can cause problems with the connective tissues. So you can have lens dislocations in the eye because the disulfide bonds can be disrupted, can cause developmental delay, and homocysteine can actually cause an increased risk of loss. So we have somebody who cannot excrete homocysteine, it's building up, and these are the problems that occur. But because cystathionine is very low in these cases, and we're shunting everything back through methionine synthase, methionine actually also becomes very high. So we take a newborn screen blood spot from the baby's heel. The cards look exactly like this, and we detect high methionine. That's the marker for homocystinuria. So if you detect high methionine, and so we now get this baby coming into our clinic. They have high methionine. We'll do follow-up testing. We'll find out that the homocysteine is high as well, and how are we going to manage it? So the first thing we're going to think about is reducing the input into the system by reducing the dietary protein. So this will have the effect of reducing methionine, and therefore there'll be less kind of going through this system. This is kind of interesting because this is a medical food. This HCU cooler has the other 19 amino acids in it, but it has no methionine. So we use things like this to supplement patients who are on a low protein diet from food. We can give them medical protein that doesn't have methionine. So they're getting, enough protein to grow and develop normally, but we're avoiding giving them something that's going to become problematic. So we're doing a low protein diet. We're giving them supplementation of protein without methionine, and we're going to give them some medications as well. So there is another medication called betaine that can help promote homocysteine to be converted back to methionine. And we're also going to prescribe our vitamins. So my B6, my B12, and my folic acid. And so the goal of all of this is to help reduce the homocysteine in the body, to reduce those risks of developmental delay and other things we can see with homocystinuria. And then we'll follow these patients forever. This is not something you grow out of. This is a lifelong condition with lifelong management. And so there is our goal. I think those are loose flavors. I have never detected the flavor of any formula that said it's supposed to taste like something. They all taste terrible. It's unfortunate. All the amino acid based. It's not good. You don't want to try. Sometimes we can make a diagnosis based on clinical features. So we had newborn screening before. Now we're seeing some kids in our clinic. What are high yield consults for us, I guess. So a metabolic emergency. I doubt anyone here has a hyperammonemic crisis and doesn't call us. If you aren't, you probably should be. Severe metabolic acidosis, particularly a severe lactic acidosis, or recurrent hypoglycemia without a clear cause, unexplained critical illnesses, or if somebody who has a critical illness that isn't acting the way you think it should. So, not typical reactions to medications, or, if somebody's having really bad seizures and nothing is working, and then we give them a dose of vitamin B6 and their seizures go away. It's a metabolic problem usually. Acute encephalopathy, hepatopathy, or myopathy without a clear explanation, and then failure of usual treatment. And previously a family history of SIDS, and I mean, that still holds true today. Back in the 80s and 90s and whatnot, before we really started screening, MCAD, so medium chain acyl-CoA dehydrogenase deficiency, is one of the most common causes of SIDS. We have reduced the risk of that with newborn screening and early treatment, and we don't tend to see that anymore. Like, we've altered the natural history of MCAD by screening, and that stands true for a lot of metabolic conditions. We've altered their natural history. And then I had actually given this talk for neurology, so I kept this in, but there's a lot of interesting CNS phenotypes that we can see, but mainly it's anything that's atypical, or if you do an MRI and the MRI doesn't look like you think it should. And last year, Melissa Carter in genetics, along with the Canadian College of Medical Genetics, published a new position statement on the appropriate investigations for neurodevelopmental disorders. And I did check this last night. This QR code still works. And so the goal of this paper was to have earlier in the diagnostic odyssey access to genetic testing. So it meant for pediatricians, neurologists, pediatric neurologists, and even family doctors if they're so inclined, but what the initial investigations for intellectual disability, autism, or other neurodevelopmental disorders should be. And I know this is going to be very small, but within this table has a list of kind of red flag features of metabolic diseases. So for instance, the first one here is developmental plateau or developmental regression. What disorders should you be considering, and what testing should you order while awaiting consult with genetics? And so hopefully the goal was, arming pediatricians and primary care providers with a document saying, these are what you need to worry about, this is what you need to do. We're going to get more referrals for kids who've already had some workup, so we can see them in a more timely manner. Because, for a long time, we had a wait list of 400 kids whose referrals just said autism. So if we could have some more of that primary testing being done before we get the referrals, and we can triage them better. And then we can also make a diagnosis based on testing. So this is back to our overview of metabolism. So we have our protein, our carbohydrates, our fat, and our micronutrients. So when I suggest a test, for instance, plasma amino acids, what I am interrogating is the breakdown of our protein. When I suggest an acylcarnitine profile, I'm interested in looking at how fats are being broken down. When I request urine organic acids, I'm looking for organic acid metabolism. Now, there's some crossover between some of these pathways, but our testing is targeted to help us look at all of the different pathways in the most comprehensive way possible. So the enzyme that's deficient in galactosemia is galactose 1-phosphate. So we will measure that enzyme if we're concerned about galactosemia. And then we can also measure some of the vitamins and minerals. And genomic sequencing is providing us with more and more of our referrals with new diagnoses of metabolic diseases. And I get the pleasure of just sowing these seeds with you guys today. Last week, Genome Sequencing Ontario, in collaboration with Ontario Health, released new guidelines for genome-wide sequencing in Ontario. So this is either exome sequencing or genome sequencing, where we're basically looking at all of the genes. They have now opened up the ability to order genetic testing to all healthcare providers. So for instance, they are broken down by system. So the first one here is neurodevelopmental indications. So global developmental delay, ID, autism with some of those red flags, or a suspected syndrome where there's multiple family members or the parents in consanguineous. So This first one, neurodevelopment, geneticist or physician specialist as per the provincial genetics program, that's pediatricians, neurologists, pediatric neurologists, and physiatrists, in addition to geneticists. So I'm sure Dr. Boycott from genetics will talk about this more later, but you are now all free to order your own exomes for neurodevelopmental conditions. I feel comfortable with that. That is totally reasonable. There's been no guidance or information provided to care providers. This is new, and I'm sure that our genetics colleagues will talk a little bit more about it going forward. That's the typical response I've seen from people so far. A few thousand. Mm-hmm. I mean, I don't think we're telling you guys to change your practice at the moment, but I'm just saying this is from last week. We got these emails last week from the government, from Ontario Health, and then a second one from GSO here at CHEO. Anyway, the field is changing. I'm not telling you guys, you don't have to go do your own exomes. I'm so happy to see your patients for you. Anyway, if you want to, there's a whole section on the Ontario Health website about the new genetics guidelines. I would not have even talked about it had it not come out literally last week. So why is diagnosis important for our patients? I have two little graphs here. The first graph is actually from 1999, where they had 370, and oh, Rachel, I'm sorry, I know I keep going back there. We had 372 different genetic disorders looked at, 1999. 12% of them were totally treatable with something. So here we had a B12 responsive methylmalonic acidemia. Some had a partial response, and some had no treatment at that time. So for instance, galactosemia, Tay-Sachs, still no treatment really for that. There was an update to this figure in 2008. So we're still talking 17 years ago. This is no longer the case. So the first purple, like the bluey purple line, is no treatment in 1983. So the first line in all of them is 1983. The brown line is 1993. And then the darker purple is 2008. So you can see if you look over time, the conditions that they looked at, and they looked at the same conditions over time. Initially, there were more things, like you could not treat anything. By 1993, we're starting to see partial treatments. And then in 2008, there were conditions that had full treatment that did not have full treatment before. So we're actually seeing a really nice improvement on our ability to treat genetic disease, but we're definitely not fully. Many IMDs are treatable, not necessarily curable, but manageable and treatable. And so we do have interventions to reduce morbidity and mortality. We may use medications, so true drugs. We may use supplements like vitamins, minerals, what have you. Therapeutic diets are these ones that may be protein restricted or protein, we're giving formulas that are missing one particular amino acid. Liver transplant is actually curative for a lot of conditions. So the urea cycle disorders in particular, swap out their liver and they're basically good to go. And we're still kind of on this precipice of gene therapy for a lot of metabolic diseases. Some exist, look promising, some look less promising. We are starting to see that the earlier you do a gene therapy, the more likely it is to be effective. They may prevent progression of the illness, but they may not fully, restore damage that had been done previously. Some of you may have come across Isla. She's one of Pranish's patients. She has a metabolic disorder called Pompe disease. And in the family, two of the older kids actually died in their first year or two of life related to complications from Pompe. Isla on the other hand, received in utero enzyme replacement therapy. This picture and this headline is from an article in the New York Times. Isla is 3.5, I think now. This is a little bit of an older video. You guys probably can't hear Pranish talking, but kids with Pompe have kids with Pompe normally do not develop motor milestones. They have severe cardiomyopathy, severe breathing issues. They're often ventilator dependent. And it would be unheard of for a kid with active Pompe not only to be 3 years old and healthy, but 3 years old and jumping. This video is probably close to a year old, but she still looks good. So this is a huge success. In Ontario, this is a big question, is where are the funding for our medications coming from? We have a whole bunch of Ontario public drug programs, and I would like to be clear, I've been in this field for 11 years and I still have to look up who pays for each drug. There is a specific program offered through the Ministry of Health called the Inherited Metabolic Disease Program. It pays for the specialty foods, so the low protein foods, all of the formulas, sometimes enteral feeds, depending on what the patient needs, some of the medications, and most of the supplements. So, we probably don't think about, thiamine being that expensive, but if you're taking a huge dose of thiamine every day for the rest of your life, it really adds up. So we're talking, hundreds to thousands of dollars a year. And then it also covers some of the more specific medications that we give. So example, Kuvan we give for some patients who have PKU, but there's also a condition where they can't make biopterin, where they need Kuvan, or they will have severe seizures, movement disorders, and what have you. So it's a very expensive medication in the realm of hundreds of thousands of dollars a year. But this program will pay for those patients because quite often private insurance will not pay for these types of patients. There is also the Exceptional Access Program. So patients who are receiving enzyme therapy for whatever their condition is often will not be covered by private insurance. We may have to go through this Exceptional Access Program and provide them every year with a full case summary of the patient, including every test that they want us to do. So this may be echocardiogram, ultrasounds, MRIs, 6-minute walk tests, response to the medication by looking at biomarkers. So our nurse Stacy spends a lot of time collecting these huge case summaries to send to the Ministry of Health every year, so these patients can continue to access their life-saving medicines. And then sometimes things may be covered by some of the private insurers. Generally, the government plans tend to be the best from what we've seen. I think that's kind of holds true through most medications. But sometimes the medications will be reimbursed by a private health plan, but not for our indications. So they may be covered for different conditions, but not for the metabolic disease we used to. And so then we may have to access through other ways, so special access. There is also a program called Drugs for Rare Diseases that provides some enzyme therapies. Once in a while, we actually get our medications directly from the pharmaceutical company, and they will just provide them on a compassionate basis to patients. Or we may get a private insurer who pays 80%, but on a drug that costs $500,000 a year, that $100,000 copay is still unrealistic for most families. And so that $20,000 or that $100,000 that's not covered by the private insurer may be picked up by the pharmaceutical company themselves. And then we also have special access approvals for some medications that may or may not be typically provided through Health Canada. And after all that, some patients do still need to pay for some things. So it's a mess. And then about a year and a half ago, the government announced a national strategy for drugs for rare diseases, which is about $1.5 billion to help support provinces in setting up pathways for patients to receive treatments. for rare disease and to get early access to new treatments, new screening, and new testing. I don't know if it's gonna allow me to open this or not, but I'm gonna give it a try. You can see here that you probably know at least one of the people on the advisory group. We've got Dr. Pranish Chakraborty, who's a part of it. So he is definitely providing good input from our perspective. And then this is my favorite journal. This is JMD, Journal of Inherited Metabolic Diseases. Last year, they actually had an entire issue dedicated to kind of where we're at with gene therapy for metabolic diseases. And so they kind of broke it down by different disease types. We're getting there, but we're not there yet. The potential benefits of gene therapy for our patients is it could allow them to stop a restrictive, for the PKU patients, their daily protein allotment, maybe 10 grams of intact protein a day. Like most of us have already had 10 grams of protein a day. And these patients are trying to work around that in their daily. We are able to give them, a formula that doesn't have phenylalanine in it. But patients often say they've never felt full. Because fat and protein is what makes you feel full when you eat. They can't eat protein. So it allows them to stop a restrictive diet and have a more normal kind of diet and a more normal social life. Because a lot of our patients are wanting to go out with their friends and really struggle to make choices that can fit into their treatment. We can reduce the medication burden. A lot of our patients are taking 20 or 30 tablets a day of whatever it is we've prescribed them. And it can prevent progression of their condition. Now, what I've alluded to before is that it may not necessarily improve the previous damage that happened, particularly in the brain. There's a lot coming this way in preclinical and clinical development. XILD has a form of gene therapy that was approved in Europe. I doubt it will be ending up approved in Canada, just looking at the type of treatment it is. And some more common genetic conditions as well have gene therapies in the pipeline. And I think PKU is going to be an interesting one. Unfortunately, we were not chosen as a site for one of the PKU gene therapies. Pranish told me that part of the requirement of me going to do Popham Fellowship was I had to talk about it at Grand Rounds. I don't think that's written anywhere, but I was told that this had to happen. So last year I did a few months with Dr. Danielle at the Magic Clinic in Calgary. This is a community-based genetics practice that's focused on clinical trials and making it more easy or more accessible for patients to enroll in trials without and she's going to sound super rogue here, without kind of being under the umbrella of a university. So he is solo in the community. He is a geneticist and a pediatrician. And when I was there, they had 30 clinical trials ongoing and a research staff with you. So he's running a total clinical genetics practice and 30 different trials on the side. It's a totally novel clinical setup. And I think it was such an amazing experience for me. So the goal of this was to get practical experience in clinical trials for rare diseases. And I know people here run clinical trials all the time. There's an endo and neuro and whatnot, but there was nothing really here related to metabolic and rare disease. And so it was just such a wonderful opportunity to kind of he allowed me to run the research team. So to have 18 people coming to me with all their questions and concerns and how to approach this from a different trial, it was a wonderful learning experience. But it also really got my name out there. So I've been back for just over a year, and I've been approached on 6 different occasions to run 6 different clinical trials here at CHEO. So last year we did launch 2 related to PKU, and the last one, which is this disease monitoring program for patients with fatty acids. I think it was and I'm looking forward to continuing to offer new clinical trials to patients going forward. And then this is kind of the state of the union for metabolics in Ontario. So IMD patients require lifelong care. As I mentioned earlier, there's 1,500 conditions, give or take. And they're very different. You know, some affect the liver, some affect the kidneys. A lot of them are neurologic. We need interdisciplinary teams. We can't just take care of them on our own. And we need pathways for them to access therapies. And if they don't get those therapies, there's high chance of morbidity and mortality. As it stands right now, IMD care is centralized to the Southern Corridor in Ontario. Ottawa covers most of it, and then everything else is kind of along the 401. Most clinics are accepting referrals across all age groups. So that includes us here at CHEO, but also kind of the smaller centers in Ontario. On the opposite hand, Sick Kids is truly only for children. And then UHN across the street from Sick Kids cares for the adult patients. And across Ontario, 40% of ongoing care is for adults, whereas in the past, metabolic care was primarily for children. This is actually a success. Our patients are no longer dying in childhood. They are becoming adults, and we need to, that's actually a good thing. Our clinic accepts referrals for children and adults with known or suspected metabolic diseases, children with a newborn screen. We do assessments for anyone with a family history of IMD, and then with unexplained seizures or unexplained neurologic dysfunction or unexplained illnesses. And so I've been talking about this with people for a really long time. Ways to improve care in Ontario include advocating to the government to fund our testing. If I send a patient out to Life Labs and I want to order my classic tests of amino acids, acylcarnitine organic acids, they're going to ask the family to pay for those tests. And I've had a lot of difficulty with some of community care providers outside of Ottawa and other parts of Ontario being like, I need you to help me order these tests at the hospital because the family is going to have to pay for it because they're not going to be able to access it at Dynacare and Life. You can maybe even see some of these red X's have white check marks behind them. The white check marks were from the first time I gave this talk a year ago. Those tests have since become unavailable to families in the community. So it's hard for us to, you know, I know you live 2 hours from CHEO, but these are your options. You can come here and the hospital will absorb the cost of your testing, or you can go to the Dynacare in whatever town you live in, but they're going to charge you $500. Like this is, we're stuck between a rock and a hard place. So this is one area where I think we need to further kind of advocate on our patients' behalf, which I don't think is well known in the general medical community, is not can be done. A lot of our clinics are facing challenges. So we have long wait lists. We've tried to accommodate patients by adding on extra clinics, double booking, things like that. The IMD program itself, while well managed at the government level, is very difficult to work with at the pharmacy level. So our medications through the IMD program can only come from dedicated IMD pharmacies. Here is the pharmacy at CHEO, and I'm sure you guys all understand how overrun kid care and the inpatient pharmacy is. But it's the only pharmacy we can use to prescribe our medication. And it's the same for all of the hospitals providing IMD care in Ontario. And one of the main issues is that, you know, we may have 2 patients on a medication in Ontario. It's difficult to negotiate prices from a public health perspective. You guys may remember a year or 2 ago, there was a contamination problem at the Abbott formula factory somewhere in Michigan or Wisconsin. While that was a problem for kids who take regular infant formula, that was the only company that was making metabolic formulas for some patients, to the point where we and all of North America were scouring Europe and Australia trying to get life-saving formulas for patients. So when something like that happens, where, you know, it's inconvenient for a family who's on regular infant formula, it is devastating, life-threatening for a kid who's on a formula that's keeping them from having, you know, a hyperammonemic crisis. And then, as I mentioned already, we're having issues facing labs. And so one of the ways that we were hoping to alleviate this was in 2022, we being the metabolic community of Canada, submitted an application to the Royal College to have IMD medicine recognized as a full Royal College specialty. I know some of you are surprised that my metabolic training is not recognized. We are not Royal College certified. We are just regular physicians who had a different specialty to start with. But in 2022, we submitted an application to the Royal College, and in August of 2024, it was accepted. So starting in some number of years in the future, you will be able to train in IMD medicine, in pediatric genetics, pediatric neurology. We included endocrinology as an entry route, as well as medical biochemistry and lab. We perceive this as being pediatric and adult specific. And it's going to be a 2-year program. There will be a 6-month lead-in where if you're coming from genetics, you probably need more exposure to ICU, exposure to nephro, what have you. If you're coming from pediatrics, you might need a little bit more exposure to genetics. And so after that 6-month lead-in, we would have everyone doing an 18 months of metabolic medicine. This is the adult medicine stream because it was actually given by a colleague of mine in adult medicine, and I didn't think to make a pediatric one, but it's the same. And so we're hoping to achieve that we'll have more doctors because, we don't have a lot. There's 3 of us here, and one of them is the head of pediatrics. So there's only 2 of us seeing all the patients here at CHEO. And, this is a field where positions go unfilled for years. If you want to be a metabolic doctor, you can basically go anywhere. Like everyone's looking for doctors. So we're hoping to have a bigger pool of people to draw from, and then to have more funding for people who want to train. Because as I mentioned, I didn't do a Royal College fellowship. I did an under-the-table fellowship at Sick Kids where I was paid out of a research grant. And then hopefully to help promote people to do this with a recognized subspecialty as well as remuneration at a subspecialty level. Until then, you're more than welcome to send us patients or come hang out with us. I know Stephanie's with us right now, but happy to take anyone from peds or any other specialty if you want to come hang out with us. See what we do. Thanks.
We'll stay right here like this, Danielle. Thank you very much. That was great clarity with regard to the biology and the biochemistry. When I was, I'm sure any of the 4th year residents are probably like, man, wish I would have had this talk from Dr. Bourque before I wrote my exam. It was super clear. We will take questions from either the audience here or anybody online.
Most half the people in this audience work at Newborn Screening Ontario or in the metabolic clinics. They may not have too many questions.
Any questions? Just maybe we need to do the part. Oh, here we go. Okay. Okay, here is a question. So where does MELAS fall into this categorization? How would it be categorized? The affected organelle being mitochondria.
Some of the mitochondrial disorders like that kind of span both small molecule and mitochondrial disorders. So sometimes we kind of put them in both buckets.
Yeah, keep scrolling down. Anything here, guys? I have a question for you, but I'll see if anybody else. Yeah, I have a couple of questions for you. Those formulae that you talked about with for the homocystinuria kids, how much do they cost?
Thousands and thousands. It would be unreasonable for families
To be able
to afford.
Okay.
Yeah.
And tell me, how similar are newborn screening programs across the country?
General conditions that are screened for in every province they're not all equivalent. Okay, so there's definitely similarities. So everyone in Canada is screening for PKU, for MCAD, hypothyroidism. But there are definitely provinces who have fewer conditions or who have different conditions. So a good example is Ontario has been screening for cystic fibrosis since 2007. Quebec added it in 2009. Yeah. There is in the United States what's called the Recommended Uniform Screening Program, or RUSP, that most jurisdictions use as a guideline as to what should be screened for. Now, we don't screen for everything on that because, you know, we have different legislation, different opinions about what an effective treatment is. So if you go to New York State, they have a very comprehensive newborn screening program that was related, that includes a lot of conditions that families had advocated may not fully be treated, and that's less of an issue here.
We have a question from Dr. McKenzie. What proportion of the liver transplantable conditions are gene therapy targets?
Well, I mean, Alex, you can use vectors that are targeted to the liver. There's not a lot of clinical gene therapy available for those conditions yet. But there's certainly AAVs that you can use that are liver targeted.
And another question from the virtual audience. Can you provide resources for guidelines of indications to do genetic testing in non-dysmorphic short stature? MELAS seems to not be considered even by pediatric endocrinologists.
I can look and see what we have. I don't see much short stature these days. MELAS, though, I would expect there to be other issues, you know, whether that be history of stroke, migraines, myopathy, what have you. I would expect it to be more than short stature, though. I mean, if you wanted, you can easily order mitochondrial DNA testing in Ontario. It's an in-province test that goes to London Health Science Centre, and the requisitions are available on their website.
Any other questions from the virtual audience? Okay, I have another question for you. So in that lovely circle where Dr. Ferreira tried to put together all of the diseases, there was something that I never even heard of. Vesicular trafficking. What is okay. Yeah. So there can be diseases in that transport.
Yeah.
Well, this thing is never even heard of.
Any enzyme or any transfer, any part of your body that can go wrong can, in theory, go wrong.
Yeah. Okay, final question from me. So, Isla. So, was the is it just a one-time gene therapy thing that she had antenatally?
Sorry, I don't know what to do with what Mark is saying. It wasn't.
We don't know. We don't know what to do, Mark. It's like, come and be here if you go here.
So what Isla had was enzyme replacement therapy that was provided antenatally and continues today. So kids who have severe Pompe disease may make, you know, antibodies to the enzyme if you give it to them after birth, and they may not do as well. And so by giving her enzyme therapy right from the get-go, her body tolerates that enzyme better, and she never had the chance to display any of the manifestations of the condition.
Right. So 9:32. Thank you very much, Danielle. That was a really good talk.